the topic of my presentation EAU guidelines, edition of prostate census of Confined. Table of content. Destination, introduction, epidemiology, etiology and risk factors, classification and staging system, diagnostic evaluation, management, research and progress. Definition. According to NCP, organ confined prostate cancer is a cancer that is inside the prostate and has not spread to the part of birth. It is stage T1 or T2 prostate cancer. Prostate cancer starts inside the cell of prostate gland. Almost all prostate cancers are adenocarcinoma. Early stage prostate cancer needs testosterone to grow. As a result, treatment will often focus on reducing or blocking the amount of testosterone. Introduction. Aim and scope. Prostate cancer guidelines. Panel has prepared these guidelines document your key medical professional evidence-based management of prostate cancer. Clinical guidelines present the evidence available to the expert, but following guidelines recommendation will not result in death of. Guidelines can never replace clinical expertise when making treatment decisions for individual patients, but rather help to focus decision of taking first value and substances individual taken into account. Guidelines are not mandated and do not form to be a real standard of care. One of the prostate, as you know, it consists of peripheral zone, central zone, and transitional zone. Peripheral zone is almost inside of the region of carcinoma of prostate. Recommendation change. For each recommendation within guidelines, there is an accompanying online strength rating form, the basis of which is modified grade methodology. These forms suggest the number of key elements mentioned. The overall quality of evidence which exists for recommendation doesn't inject or rating according to the classification system modified form of code Center for Evidence-Based Medicine Development evidence. The magnitude of effect here of the bio effect, the certainty of result, the balance between desirable and undesirable outcomes, the impact of patient values and preferences on intervention, the certainty of those patient values and preferences.
Now, just a word about guidelines. Whenever we talk about guidelines, there is always an impression that we have to put patients into guidelines. It is not the case. The case is the guidelines are those recommendations that have got strength, as you have pointed out in this slide, and this is what we call evidence-based practice of medicine. Whenever we have got, for instance, treatment A for a disease B, then it is on the basis of certain evidences, and those evidences should have been judged through kind of strengths. Now, for instance, I might say that whenever I have got a patient with the lower urinary tract symptom, I always try ciproxin. Now, this is something which has to be backed by some references, some evidences that have got some strength. Otherwise, this will be regarded as just an impression. It is just a personal experience. Now, personal experiences have got their own importance, but whenever you want to talk on a platform, on a podium, in the community of doctors, or in an institution, making a policy for everybody to follow, then you have to have a lot of other parameters, other tools, and one of these tools is what we are actually discussing. So guidelines are those which provide you something which is reliable, something which is reproducible, something which has got an impact, and it has been a practice and combined effect of combined effort of a lot of people. So it has got kind of credibility that it enjoys, and again it reflects on patient outcome. So uh, whenever you have got a patient, it is not necessary that you put your patient and look for something, whether guideline is saying something for my patient, something related to the symptom complex that the patient is actually narrating. But the guidelines should always guide you to decide something for your patient. So it has to be a two-way communication rather a one-way communication. So it is not necessary to just put your patient into some sort of a box and then look for the box where that box is in the flow chart of the guideline. So whenever you think about a guideline, whether it is for oncology or whether it is for urolithiasis or any disease aspect, you have to take it with a lot of say a lot of with a lot of a broad view rather than a narrow view. So that's my take on this aspect. So please continue.
The strength of each implementation is presented by our response of these. The strength of each implementation is determined by the balance between desirable and undesirable consequences of alternative management strategies. The quality of evidence, including the certainty of estimates and data and validity of patient value and test. Epidemiology. Prostate cancer is second most common diagnosed cancer in men. It is estimated 1.1 million diagnosed worldwide in 2012, accounting for 15% of all cancer diagnoses. Frequency of prostate-detected prostate cancer is roughly the same worldwide. A systemic review of prostate studies reported a prevalence of prostate cancer at age less than 30 years of 5% and prevalence to 48 to 70% by age more than 79 years. Etiology. Family history and genetics. Family history and racial and ethnic background are associated with prostate cancer incidence, suggesting a genetic predisposition. Only a small subpopulation of men in prostate cancer, approximately 9%, has two hereditary disease. This is defined as 3 or more characteristic variances or at least 2 relatives who have early onset of prostate cancer less than 5 years of age. Hereditary prostate cancer is associated with a 6 to 7 years earlier disease onset. Ancestry specific risk loci have been identified and known by studies have identified more than 100 common susceptibility loci of prostate cancer. Germline mutations have also been increasingly identified among men with non-hereditary prostate cancer. Mutations were commonly seen in BRCA2, ATM, CH2, BRCA1, and PALB2. This factor. A wide variety of physical or environmental factors are associated with the risk of prostate cancer. Japanese men have a lower prostate cancer risk as compared to men from Western world. However, as Japanese men move from Japan to California, their risk of prostate cancer increases, approaching that of American men, playing a role of environmental factors. Metabolic syndrome. Hypertension acting to associated significantly and greater risk of prostate cancer, but in total having more than 3 components of medical association are used. Diabetes and metformin. Metformin users, but not other oral hypoglycemic agents for how to be at increased risk of prostate cancer, diabetes associated with never due. Cholesterol and statin. And associated with blood cholesterol, high in cholesterol levels at the risk of either overall prostate cancer or high grade prostate cancer. That is also didn't show us the negative effect of statin on prostate cancer. Obesity was associated with lower risk of low grade prostate cancer, but increased risk of high grade prostate cancer. Dietary factors. The association between a wide variety of dietary factors are associated with prostate cancer. Dietary factors include alcohol, dairy products, fat, metals, meat, soya, vitamin D, vitamin C, and selenium. Other potential risk factors include morbidity, pneumonia, smoking, cadmium, non-positive for clinical coronavirus, hysterectomy, and self-reported technique. Studies also shows higher injection frequency, more than 51 times per month versus 47 times, has been associated with 20% lower risk of prostate cancer. Other potential risk factors. Summary of this prostate cancer is a major cancer in men with is mainly dependent on age. Genetic factors are associated with risk of aggressive prostate cancer. A variety of diseases or environmental factors may have an impact on prostate cancer and the risk of progression. Selenium or vitamin C supplements have no beneficial effect in prostate cancer. In hypoglycemic men, testosterone supplements do not increase the risk of prostate cancer. The recommendations are no specific preventive or dietary measures are recommended to reduce the risk of developing prostate cancer. Classification and staging system. Classification, the objective of tumor classification is that classification is to combine patient with similar clinical outcomes. This allows for design of clinical trial on homogeneous patient population. The comparison of clinical and pathological data obtained from different hospitals for the world and the development of recommendations for the treatment of same patient population. Human staging for prostate cancer. TX cannot be assessed, no evidence of primary tumor, AIS, carcinoma in situ. T1 less than 5% of cases detected for benign disease as cancer in normal DIAGNOSTIC. T1B, more than 5% of cases detected for benign disease as cancer in normal DIAGNOSTIC. T1C detected from elevated PSA around normal DRE and E. T2A, tumor detectable by DRE or visible by CT, volume less than half of 1 log of prostate. In T2B, a tumor detectable by DRE or visible by CT, volume more than half of 1 log of prostate. In T2C, tumor detectable by DRE or visible by CT, volume 4 logs of prostate. In PSA, they detect vascular cancer on one or both sides. T3 and T4 is not related to hospital one. And renal node is node. Obturator internal C-cycle is node. And cannot be assessed and not original node metastasis and one metastasis in a original node or node. And for distant metastasis, MX cannot be assessed and not no distant metastasis. And one A distant metastasis to non-totally node, and one B distant metastasis to node, and one C distant metastasis to other sites. There is a core and international study of universal 2014 rate. In the basis for 2 to 6, basis for and IS grade. Basis for 2 to 6, this time grade 1, 4 of 3 plus 4 for grade 2, basis for of 4 plus 3 for grade 3. 4 for 8 for grade 4 and 4 of 9 to 10 for IS grade 1. Guidance for classification is the recommendations are use the PNM classification for staging of prostate cancer and the use of intervention status to versus the following process for grading of prostate cancer. Diagnostic evaluation. We can consider basic screening to predict the receiving mortality. In 2012, the US preventive services are support to release the recommendations against non-selective PSA screening, which was adopted in 2013 guidelines. Guidance for screening and related recommendations are do not suggest men to prostate testing below only then on the friends report and benefit. Offer and individualized risk of testing for early detection who are well informed and a life expectancy of at least 10 to 15 years. Offer early PSA testing to well informed men at a reduced risk of having prostate cancer. Men more than 50 years of age, men more than 45 years of age and a family history of prostate cancer, men of population history more than 45 years of age, men carrying BRCA2 mutation more than 40 years of age. Other risk prostate testing is based on initial PSA levels with follow-up intervals up to 2 years for those who at risk. Men with PSA level more than 1 mg per ml at 40 years of age and with PSA level more than 2 mg per ml at years of age. For straight follow-up to up to 8 years in those who are not at risk. For early diagnosis of prostate cancer is based on life expectancy and performance status. Men who have a life expectancy of less than 15 years are unlikely to get men. Clinical diagnosis. Prostate cancer is usually detected on the basis of DRE or PSA levels. Definitive diagnosis depends on histological verification of identified common prostate polyp. Usual examination. PCA on treating factors don't and may be detected by DRE when the volume is more than 0.2 ml. In approximately 18% of cases, prostate cancer is detected by DRE alone, irrespective of PSA level. DRE in patients with PSA level less than 2 nanogram per ml has positive predictive value. It is about 5 to 30%. And normal DRE is increased of higher IS grade and is an indication for biopsy. Prostate test antigen. To use the use of PSA as a marker as revolutionized the prostate cancer diagnosis. Prostate specific antigen organ but not manufactured. Therefore, it may be elevated in benign prostate, prostate and other malignant. standard defined for measuring PSA. It is a continuous parameter with higher levels indicating greater length of prostate. Many men may harbor prostate cancer despite having low the PSA level. PSA density. The higher the PSA density, the more likely it is that the prostate cancer is immediately. Risk of prostate cancer in relation to low PSA level. The PSA level up to 0.5 nanogram per ml, risk of prostate cancer is 0.6%, and risk of ISU rate is 0.8%. Similarly, as the level of PSA are raised, raising the risk of prostate cancer and ISU rate also is increasing. Like PSA levels from 3.1 to 4.0, the risk of prostate cancer is 0.9, and risk of ISU rate is 0.7%.
Now here I want to say one thing more. Whenever you are dealing with a patient with suspected prostate cancer, these aspects of PSA in the management of prostate cancer should be taken into consideration, because no single thing can give you a positive clue that this patient will have a positive biopsy and will be having prostate cancer. For instance, if you have got a PSA which is maybe less than 2, and on DRE, if the suspicion is that this is a stony hard prostate, then you must rely and give importance to your DRE finding and do biopsy, because then the determining factor is probably a clinical impression which is felt by the finger. But this is very important, because if the PSA is higher, this is just because of the reason that the tumor is differentiated, meaning to say that this is, as you have said in your previous slides, there are 5 different grades of differentiation from 1 to 5, and on that basis we always calculate Gleason score and Gleason grade. Now, this grading of differentiation is for well differentiation, meaning to say you have identified the identity of the cancerous cell, which is adenocarcinoma prostate. Now, if this happens to be a poorly differentiated cancer, then this will not be having PSA as something coming up as its serological identity. And for a poorly differentiated adenocarcinoma of prostate, PSA will not be that high. It might be less than normal or within normal range. So for those cases which are poorly differentiated, if you want to pick them up, it might not be because of PSA value, it will be your clinical judgment and probably your finger, which can give you a kind of a filter by which you can just pick your patients who happen to be in that group, a poorly differentiated group.
Yes. Let's say velocity and data. There are 2 methods of measuring PSA content. PSA velocity absolute and will increase given for given PSA level nanogram per ml per liter. PSA repeat time with higher exponential increase in serum PSA over the time. Guidance for risk assessment of asymptomatic. The recommendations are to avoid unnecessary biopsies of further risk assessment to asymptomatic men with a normal digital bacterial activity and prostate cancer level 2 to 10 nanograms per ml prior to performing a prostate biopsy. Use one of polycode risk calculator, imaging, and traditional serum or urine based test. imaging. Thus, guide prostate biopsies and other prostate directed interventions. Endorectal MRI, accuracy of endorectal MRI varies from 1 to 92%. FDA is an MRI, bone scan, antibodies. Antibody is actually approved for initial staging and treatment. Guidance for using prostate cancer detection. Recommendation for all patients. Do not use multi-test MRI as an initial stage. Adhere to FDA audience guidance for NPMRI acquisition and interpretation and evaluate NPMRI results in multi-disciplinary pathological research. Recommendation in biopsy in hybrid. Form NPMRI before prostate biopsy. When NPMRI is positive, combined targeted and systematic follow. When NPMRI is negative and clinical prostate cancer is low, omit biopsy based on shared history making mistake. Recommendation in patient required negative biopsy. Form NPMRI before prostate biopsy. When NPMRI is positive, perform targeted biopsy. When NPMRI is negative and clinical suspicion of prostate cancer is high, perform systematic biopsy based on shared decision making in patient. Recommended terminology for report prostate biopsy. Recommended terminology is benign or negative for diagnosis, for agency, appropriate, use for active inflammation, rheumatic inflammation, high-grade prostatic area, high-grade atypical gland, for adenocarcinoma. Focus on atypical gland for lesions for adenocarcinoma or atypical small acinar proliferation, specific for cancer. Adenocarcinoma and intrahepatic carcinoma. Diagnosis of prostate cancer. Pathology, diagnostic category includes cancer, majority and major and minor features, pancreatic cancer and features against cancer. And studying and additional second procedure. Half prostate biopsy that does not contain glandular reporting as diagnostically inadequate. Mandatory elements to be reported for carcinoma positive prostate biopsy are type of carcinoma, primary and secondary or what stage, percentage high-grade carcinoma, extent of carcinoma in mm or percentage, at least for biopsy site. EPIDEMIOLOgy, technical lesion, geriatric carcinoma, or uniform section, and peri-uterine.
Now, if I want to just explain to you what you are saying, whenever a biopsy is done, it has to be mapped, and it has to be mapped by means of something on a paper. And whatever you are seeing is actually through the transrectal probe. Now, the biopsy is done either transrectally or it is done through the transperineal route, but the imaging or the guidance of the biopsy needle is by means of an ultrasound probe that is within the rectum. So the imaging is transrectal ultrasound. Needle can go through the rectum or it can go through the perineum. So whatever image is there It is the image which is picked up by the transrectal ultrasound probe, and whatever you see on an image, either it's on a long axis or it is on a transverse axis, and these two images have got two different shapes. So you draw that shape on a piece of paper, and the point at which you are taking the biopsy from the right lobe or the left lobe, closer to the apex or closer to the base of the prostate, it has to be mapped. It has to be mapped on the figure that you have drawn on a piece of paper. Now, everybody who wants to do biopsy, whether he is a radiologist or a urologist, this information of taking the biopsy is very important. Now, this is about the location from where you have taken the biopsy. The second thing is how much is the tissue which you have taken. For instance, this needle goes into the prostate and then it comes out. The needle is a hollow needle, and the needle has got its own gauge. Now, it might be a 18 gauge needle or it might be a 16 gauge needle. Now, these two gauges are actually the cross-sectional diameters of those hollow needles. Now, the amount of tissue is different from 18 gauge needle and from 16 gauge needle. Now, that has to be again written down on the paper, on the say the piece of paper which you are actually sending. So this is an application to the histopathologist that you are sending this sample, and this sample is taken from that area, and the amount of tissue which you are providing is through a needle which is of which caliber. Now, this is very important because the tissue which you are sending is actually the thing that is being seen by the histopathologist. The lesser amount of tissue, if you send it, there will be an inadequate sort of reporting on that kind of tissue. So it is very important. It is not only necessary to pinpoint from which area you have taken, but also what volume of tissue you are sending. Now, what happens? For instance, needle number 1 or biopsy number 1 is taken from the apex of the prostate on the right lobe of the prostate, and you have used an 18 gauge needle. Now, whenever this tissue is taken out into the bottle, now that is then processed by the histopathologist, and he will see the whole tubal structure of that biopsy specimen. And when he sees it, then he or she will always tell us that number 1, is there the presence of adenocarcinoma? Number 2, what percentage of tissue is involved by the cancer? Maybe it's the 50% of tissue involved, maybe it's the 20%, maybe there is no involvement of tissue, so the biopsy is negative. So this is very important because everything is actually producing a kind of assessment in the mind of the interpreter, that what is the volume of disease the person is actually carrying, and it all has got its own implication on the treatment strategy that you want to propose. So for the time being, as you are listening to us, it is important to just register this thing, that the process of biopsy in the case of prostate is not only interesting, but it is very, very important from both the ends, from the reporting end as well as from the interpretation end. So interpretation is done by us, the clinicians, and reporting is done by the histopathologist, but both of them are very important. For instance, if one of the biopsies is taken from 5 or 7 o'clock position of the prostate closer to the base, then these are the 2 points which are actually the exit and the entry point for neurovascular bundles. So any prostatic tissue turning into malignancy closer to these points will have the greater opportunity of metastasizing to distant locations. So this is something which is interesting, and when you are with us in oncology clinic, and we'll be able to talk about this thing in more elaborate fashion. Yes, please continue.
Mainly elements provided by the pathology board. Pathological type, more than 95% of prostate cancer is still present as an adenocarcinoma. Rating according to ISCD grade, presence of adenocarcinoma, tumor circulation and surgical mark status, location and extent of EPE, presence of bladder and region, geography, sending respiratory region, location, and quality surgical marks. Additional information may be provided for multi-category and level of volume and donor indication of next week. Pathology of processing of radical property specimen and the clinical evaluation of pathological case, verify where and surgical margin of prostate cancer. It is mandated that RT specimens are to be embedded to enable the assessment of cancer location, multiplicity, and pathology. For effectiveness, partial embedding may also be considered, particularly for prostate more than usual. The most widely accepted method includes complete red box to completed prostate and a single beam entity left and right side. Compared with total embedding, partial embedding detects 98% of prostate cancer in an highest grade more than 2 is accurate, leading to 90% of cases. Guidelines for processing prostatectomy specimen. Radical prostatectomy specimen reports and pathology reports provide a special information on progressive practice values for stable EAU. The recommendations are total ready by dimension of whole non-total. Second, in the entire surface property to evaluate the surgical margin, examine the apex and base separately, using the cone method with scatter of radical or radial section. Second, reporting on prostate specimen. Histopathological type, it is a type of carcinoma. So it is great. Primary, secondary, or tertiary is used for global IS grade and approximate grade 4 or 5. Pathological stage, if extraoperative cancer is present, it indicates whether it is focal or sensitive. Specified size indicates whether there is any resistance. If applicable, it is more location and number of nodes required and number of nodes involved. Surgical margin, this carcinoma is celebrated margin, is specified size. Other presence of vascular or central region, location of dominant tumor and presence of intraductal carcinoma or minimum of 5%. Guidelines for clinical diagnosis of prostate. Medicine of perform prostatic prostate video biopsy with antibiotic protection. Do the local anesthesia by sparing prostatic infiltration or prostate video biopsy. Do not offer non-cognitive transmission to actually report the biopsy. into those test dates. Before that, prostate for four biopsies from different sites for processing and pathology reporting. Guidance for staging of prostate cancer. Any staging use pre-biopsy and MRI for local staging information. In those localized disease, do not use traditional imaging for staging purposes. Intermediate risk disease in IHC rate more than 50. It includes at least cross-sectional abdominopelvic disease and bone scan for metastatic stage. In high-risk localized disease or locally advanced disease, perform metastatic disease including at least cross-sectional abdominopelvic disease and bone scan. Evaluating health status and life expectancy. Evaluation of life expectancy and health status is important in clinical decision-making, and of prostate. Prostate cancer is common in older men and elderly men. More than 65 years result in 70% increase in diagnosis by 20-30 years and 2 years. Geriatric treatment is the international SIUT prostate cancer working group recommends that treatment for senior adults should be based on a systematic evaluation of health status using the PSA screening tool. Healthy patients with PSA score more than 40 or vulnerable patients with reversible impairment should receive the same treatment as others. While patients with irreversible impairment should receive rapid treatment, patients who are too ill should receive only palliative treatment. Patients with GH score less than 40 should undergo full geriatric evaluation. DIAGNOSTIC staging course. Staging course if the patient has good intake, has food intake decline over the past 3 months due to loss of appetite, digestive problems, falling difficulties. Therefore, should be according to their duty like 0 for severe diseases, would be one for moderate disease, would be 2 for no disease intake. Similarly, weight loss during the last 3 months, mobility and psychological problems, BMI should take more per day in comparison with other people of same age. How does the patient consider these are and age of the total for after 7
Now, what is the age at which geriatric group starts?
it is
More than 65 or more than 75? I mean, it depends upon the life expectancy of the geographical area in which you are working. Maybe the geriatric group in our population, in our country, is like 70 years or 75 years plus. Maybe in Europe it is like 80 years plus. So it depends upon the life expectancy. There is no hard and fast rule at which you want to label a person a geriatric group person or otherwise. The disease which we are talking about, prostatic carcinoma, it can happen at any age between the age of 45 years and beyond. But normally we see a majority of people between the age group of 60 years plus. So if it starts at 60 years, it starts means it gives you the clinical impression, and then you have got more majority of people between between 60 and 70, and beyond 70 you have got less number of people who are actually living. So it is rather very difficult for us in our geographical region to have such patients who are like maybe 80 years and beyond. But for those living in Europe and America, this population is too large a population, so much so that they have got specialists for geriatric problems. They have got psychologists who are geriatric psychologists. They have got endocrinologists who are geriatric endocrinologists, and so forth. So this is an interesting area. As we progress and as the health standards improve, we will be seeing a lot of geriatric people around us also. Yes, please.
History of Prostate in more than 7 years, in the year and for years for more than 14, more geriatric related is needed. It is good one it's a years for less than 14, up to genetic validation is mandatory. It includes knowledge, area, weight loss, and comorbidities, CSRT, grade 1 to 2. Then we are moved into group 2 vulnerable and group 3 and pathology. Guidelines for evaluating health status and life expectancy. The recommendations are use individual life expectancy as status and for modification of the use the state and means of proof of a form of special geriatric evaluation in cases needed for less than 4. Consider standard treatment in vulnerable patients with vascular impairment. Similar treatment with less than more than 10 years. Offer adopted treatment to patients with irreversible impairment. Offers symptoms directly probably alone to side treatment. Treatment. Different treatment active surveillance and working with in localized disease like the principle of the 10 years is considered mandatory for any benefit from locality. Active surveillance aims to avoid unnecessary treatment in men with basically localized prostate cancer. They do not require treatment, but at the same time keep the effect time for treatment. Patient remains under close surveillance through state surveillance program with regular follow-up and curative treatment. Definition of active surveillance and mortality. Treatment intent in active surveillance is curative, watching reduce quality. Follow predefined schedules and watching reduce assessment and marking use in active surveillance GRE, PSA, the biopsy and BMI, watching reduce not predefined. Life expectancy in active surveillance is more than 10 years, mortality less than 10 years. In minimize treatment related toxicity without compromising provider, while in watching rating minimize treatment related toxicity. Mainly in active surveillance, mainly those patients in watching rating can apply to all patients in all schools. The goal of practice of any both is the diagnostic function. While whenever possible, is having organ. The procedure involves removing the entire prostate with its capsule intact and semi vesicle, followed by undertaking the urine. Pre-operative application. Pre-operative application with prostate model to optimize the standard care. Pre-operative pelvic floor effect. Pre-operative pelvic pelvic using a remote biofeedback that is used with the aim of reducing this early post-operative involvement.
Now, just a word about this 3D printing of prostate models. Somebody can ask you, what is the place of 3D printing in urology? So, an answer should be that 3D printing always helps surgeons to prepare, to pre-plan their procedures accurately. So, if you want to exercise something which is like detailing your procedure and detailing it to an extent that there is nothing which is left in terms of when it happens, so it can be taken care of on the spot. This is not on in today's world. Whatever that has been happening or that is expected to happen should always be pre-managed, meaning to say you must know it to the finest details what will happen to the patient when you do surgery, in terms of both, in terms of anesthesia and anesthetic consequences whenever it happens, and also when you want to do surgery on a patient, it has to be detailed to the last point, to the last minute complications that can occur. Gone were the days when something called morbidity and complications are expected, and they say that if you do surgery, there has to be complications. Yes, that is true for a lot of cases, a lot of times. But then this is the time when you have got tools, and then anybody can ask you, if you have got a lot of tools, a lot of procedural management strategies, why don't you just did something preemptively? So this is not expected and accepted today that somebody can just give you a prescription that I want to do radical prostatectomy, for instance, or radical nephrectomy, and then the person or the family comes to know that after the procedure the patient is on a ventilator and there has been a lot of bleeding, and now you have to be with the patient. Aap dua kare, the patient can come out on his own. So these things, maybe somebody in our country, or maybe somebody in Asia or in any part of the world, can take it as a consequence of operation or procedure or medical treatment. But this is not something which is accepted these days. Same goes with 3D printing. Whenever we want to plan something, we were actually discussing nephrometry score yesterday. This was the same thing. We were actually imagining things in complexity in a three-dimensional aspect. For instance, if you want to operate on a prostate, you must know what is in front of the prostate and what are on the sides of the prostate and what is on the back of the prostate. Maybe the cancerous focus within the prostate is actually on the surface, meaning to say closer to the prostatic capsule. Maybe it is on the right side, maybe it is on the left side, maybe it is going on to the posterior aspect, involving the seminal vesicles. Now, all these things do matter, and they matter because whenever you want to take out the prostate, you have to reconstitute the integrity of the bladder and the urethra. You have to anastomose the bladder base with or the bladder neck with the urethra, and then this thing will always come into play for the continence mechanism that you have to be you have to restore, or you are planning to restore in times to come post-operatively. Now, if you want to do radical prostatectomy, there is a thing called nerve sparing technique. Now, why these nerves are spared? Because they have got an importance. They have got importance in a lot of ways. We'll talk about those ways later. But the thing is, if you want to spare the nerves, then the nerves should be spared not for the purpose of sparing alone, but for the purpose of sparing plus clearance of the cancerous tissue. For instance, if you leave behind cancerous tissue and you leave behind the nerves, then there is no point in doing radical prostatectomy. Meaning to say, if the prostate cancer is closer to the surface and it is closer to the area which is in the vicinity of the running of these nerves, then the nerves should not be spared. Rather, they should be sacrificed. They should be taken into the dissection. They have to be sacrificed because the tumor is too close to the nerves. There is no point in saving the nerves and leaving a tumor along with it. You get my point? And this can only be done through a different kind of imaging. Either you do a 3D imaging on a CT scan, or you do a 3D printing, and then you can judge at which plane you have to dissect the whole organ. If you don't do it, you will always be in a fix whether you have done it correctly or you haven't done it correctly. So whenever we want to practice in 21st century, there is always some criticism or some, say, questions from our colleagues, from our peers, that this can be done and this has to be done. And if you take into consideration in your planning procedure something called 3D imaging and 3D printing, it will become easier for you to devise your strategy, to devise your dissecting plane. So we'll talk about these things later also, but for the time being, you must understand that there is an importance for three-dimensional printing and three-dimensional planning. Yes, please. Yes, Mustafa.
Dr. Ali? नहीं, आपकी आवाज़ सही नहीं आ रही है. जी अली, जी डॉक्टर अली.
जी अभी आवाज आ रही है आपको?
जी अभी आवाज़ आ रही है.
Prophylactic antibiotics should be used, however, no high-level evidence is available to recommend specific prophylactic antibiotic prior to asking. In addition, as which of bacterial pathogens and antibiotics availability varies worldwide, any use of prophylactic antibiotics should adhere to local guidelines. Surgical technique. Prostatectomy can be performed by open laparoscopy or the technology has combined the improved service the concentration of the user. and has now become the preferred imaging method approach where there is split level. Robotic anti-gravity study robots in party has been from where we are both. First, grouping of bladder was discovered. However, recently the body approach has gained favor, falling to arguing to improve early post-stage confidence. This approach really at the focus level. First, dissecting the seminal vessel and progressing already behind the posterior. All of the intermediate force are avoided, giving type of mental part saying I offers the skill advantage as the focus carries the goal, but without the use of verification. In that, very critical to beginning of RT and ILT. Predicted probability of students include bladder health context anastomotic leak, infections, organ injury, eyelids, and deep vein problems. Radiation topics. Radiation topics. Radiation topic healthy mobility topic which are below any guided radiation topic. Both for EPIDEMIOLOgy. EM over IMRT techniques allow for more in-depth distribution of flow through liver treatment grid and provide intake alcohol which are particularly useful as patient reactors. Radio substitution planning for IMRT with some form of image-guided radiography with organ movement can be visualized and corrected for in real time. Tomography is another key for delivery of IMRT, which is analog to pilot. Normal and human and slowly those cells are very active and moving function. Later has added advantage of being more immune for patients at this lower cost. Profound being and being for an effective alternative to proton beam RT for prostate cancer. Radiotherapy. Low-dose radiotherapy use radiation suite permanently inserted into the prostate. And high-dose radiotherapy uses a radiation source temporarily into the prostate to give radiation. Here are differences between LDR and SDR radiotherapy. Low-dose LDR in LDR, a permanent sheet is inserted to iodine or radium or radium isotope. Radiation was given for week and month. The two types of effects resolve over months. Radiation protected is phosphate and can. In ACR, implantation of isotope, radiation does those liver and liver through side effects resolve over week. No radiation protection for the patient or the urology chosen. Using hormone agents, using hormone antagonists, anti-androgen, which include steroidal androgen and non-steroidal. Different androgen topics. Investigation topic of disease need to use cell death by dehydration, resulting from dehydration. Direct structure of cellular membrane by oxygen and vascular space and microthrombi, resulting in of micro already seen the problem. High intensity high intensity mechanical and thermal effects as well as by cavity. High intensity focus performed under general or spinal anesthesia with different lining lateral or spinal. Focus topic is testing activity only the tumor by very the novel model. Next focus topic is to try out SIUT laser. General guidelines for active treatment. Recommendations are inform patients that no active treatment is
डॉक्टर जी आपकी आवाज़ ही नहीं आ रही.
After a watchful policy, who is provide patient with life expectancy and years. Hello.
जी जी
आवाज आ रही था?
ये बारी.
जी जी आ रही. जी बोले.
That all active treatment has started. Surgical treatment. Once patient gets no surgical, has to treatment in order to term of cost of after the intensity mobility grading for EAU for CT of prostate. After moderate high mark of only offers token file setting or build design process. Treatment by Mainly for men with low is over treatment and therefore there should be procedure for all diseases. Guidance for treatment of low disease. Recommendations are active surveillance. Offer care to patients with life expectancy more than 10 years and low disease. The patient has had upfront paramedic MRI followed by medicine and target biopsy. There is no need for medical biopsy. Patients with introduction and this form pathology on biopsy should be from air. If required, required to form MRI report medical biopsy. Take both targeted biopsy and medical biopsy if biopsy performed. Perform serum PSA assessment, perform DIAGNOSTIC biopsy should be performed in assessment of PSA. So, getting clinical prevention of DIAGNOSTIC during follow-up, if antibody is effective and clinical treatment of prostate cancer progression so this product based on nuclear disease in stage. Also, talking about the possibility of giving further treatment. Active treatment. Active treatment of surgery and reducing costing as alternative to care to patients as suitable for such treatment and to set perspective of reproduction and greater treatment providers. Every those do not perform a care reduce some therapy. It offers those grades taking us to patients with low risk of prostate cancer. Without a previous translation of prostate is a good intervention for prostatic cell and of prostate volume less than 50. Those intensive mobility radiation population of 7 to 8 million or rate affecting the body without androgen regulating population. Other therapeutic options only offer whole-gland treatment or focal treatment, minimum clinical trial setting or well-designed practice for surgery. Treatment of intermediate disease. Guidance for treatment of intermediate disease. Recommendations of active surveillance offer air to high risk patients assessing the central risk of further medical disease. Regular prostatectomy offer hospital patients with intermediate disease and life expectancy of more than 10 years. Offer necessary surgery to the patient with low risk of SIUT disease. Can you note perform an EPIDEMIOLOgy intermediate diseases activities for causing these more sleep pulses. Radiotherapeutic treatment offer low dose radiation to gastric patients. Patients without a previous protection of prostate to intermediate prostate before and prostate volume less than 50. For general therapy, use a total dose of 76 to 78 million or more rate in combination with short-term and newer units plus androgen deprivation toxins. In patients not being 200 or 80 units and specific dose of EPIDEMIOLOGY or combination with medication. Other therapeutic options are only offer whole-gland ablation or focal ablation ability for intermediate instead of limited by setting on well-designed perspective for study. Do not offer editing monoscopy or to intermediate with case information and not able to obtain any local treatment. Treatment of high localized disease. Recommendation or dental prostate also all cases that is treated with high localized prostate cancer as a part of multi prostate therapy. EPIDEMIOLOgy perform and EPIDEMIOLOgy in high prostate cancer do not perform. Radiotherapeutic treatment in patients with high localized disease EAU.
जी जी बोलें बोलें
EPRT 72 to 78 long term androgen and vegetative salt. In patients with high localized disease, EPRT is breaking therapy goes in combination with long term treatment. Therapy often outside the and do not offer either Godian or total therapy to high patients. Do not use technique monoscopy in asymptomatic. Treatment of localized advanced prostate cancer. Recommendation of the rectal prostate offer RP to high expectancy with CT to before and not cost and payment only as part of multimodal. EPIDEMIOLOgy performed in high prostate cancer. Radiotherapeutic treatment is locally advanced offer long term and vision offers long term safety for at least 2 years. Therapeutic option outside resident radiotherapy do not offer urgent treatment or focused treatment to high patients. Only offer ADT monoscopy to those patients on those patients only or on if they have prostate cancer and still resident time less than 12 and either PSA level more than 59%. Only recently tumor after progress to local disease. After patients with stable disease, a local treatment plus long-term disease. And treatment of the rectal process. Treatment study are using complicated into diseases that become severe. Guidance was treatment of the rectal process. The conditions are do not discuss ADP in PNO stated offers adjuvant deviated to high set. Discuss the management of the patient offer and extended more than based on more than important tests. Offers adjuvant maybe offer ADP with additional offers observations to patients after a year and less than 2 volts microphone environment and PSA level less than 1 nanogram per ml and active of extramural. Guidance for non-curative or palliative treatment of patients are working ready for the prostate. After working ready for 2 patients, not eligible for local treatment and those with short life expectancy. Working ready for local advanced prostate. After artificial treatment for using ADP and not with asymptomatic patients with PSA more than 12 months and a PSA level less than 15 nanogram per ml and very specific who are unable to receive any form of therapy. persistent PSA after radical process. It means 5 millimeters of men continue to have detectable or persistent PSA after RP. It may result from local injury or benign prostate. Recommendation for management of persistent PSA after radical process. Recommendations are upper prostate and tomography can to men with persistent PSA more than 42 nanogram per ml to assume metastatic. Treatment with no element of metastatic disease is present copy and normal form. Management of PSA only leading after treatment with curative intent. Between 27 and 50% of all patients undergo either RT or RT12 IVPSA level. Guidelines for imaging patients with biochemical reagent. PSA reagent after radical process. The form of PSA would be if PSA level is more than 0.2 nanogram and if the lead is treatment. In case of examined or there is not available, and the PSA level is more than 1, perform flowing the PET hospital or to use the PET scan or if the after radiation. Perform from dates and medical localized normal area and guide biopsy taking for local services. Perform PSA and injection for creating a dialysis. Guidance for second line drugs after treatment recommendations for biochemical reagents after
Only you can skip it. You just skip this slide. Right. Thank you very much. So a good presentation and a very detailed presentation again. Just a word, for any localized prostate cancer, what is more important is to first stage the disease properly, and after that the treatment of choice is radical prostatectomy if that is possible. Now, if radical prostatectomy is somehow not the treatment of choice in that particular patient, then the second best would be to have a brachytherapy or a sandwich therapy, which is a combination of brachytherapy plus external beam radiation. If the disease is locally invasive, which by that we mean that that disease has involved the local lymph nodes, then this is something for the anti-androgens to play with. So by all means, all these guidelines, they put you into some sort of clarity and give you a total picture or a whole scenario with many variations of patient presentation, and then you can choose from all these three modalities of treatment that I have just alluded to. So I think we have crossed the time limit today. We'll be meeting next tomorrow, and then I have already proposed to you a schedule so that we can cover everything by Saturday next week, and that would be 29th of Ramzan. So thank you very much. Hafiz.